primary care practices all over the state do a fantastic job, but particularly in small practices, even though they have electronic health records, they don't have the tools to recognize patients at high risk quickly and then go ahead and implement evidence-based treatment. We're working with Community Care of North Carolina, and they have developed a system where practices can push EHR data to this system, and then the system can harvest that data in a way where they can where it can automatically identify high-risk patients. Then those lists of high-risk patients end up being provided to the practices. Now that in itself doesn't fix the problem, because if a patient's just out there floating in space, that doesn't make them better. The practice has to design a system where they can bring those patients in, look at their particular risk factors, then ensure that the lifestyle changes and treatments that attenuate those risk factors get applied in an efficient manner. And the informatics tools that will be available, but then through UNC and the AHEC program, practices will have access to expert consultants to help them go over the data for all the things that might help their patients in this study. And they'll also have access to a unique workforce called quality improvement consultants or practice coaches. And these folks are experts in building systems and workflow redesign. We are going to start contacting practices very soon, within the next week or two. And our goals are very ambitious. We want to work with at least 300 practices across the state, and we really want to emphasize small practices that we define as having 10 primary care providers or less at the practice site. And so again, when you look at North Carolina, we are in the heart of the stroke belt, and cardiovascular death is the #1 cause of death in the state. And these problems are even tougher in rural areas. So we really want to bring in these small practices so that they can get these systems to engage and re-engage their patients. And together I think we can make a really significant impact for upwards of 1 million people. But the university has been kind enough to waive a lot of the fees that normally go to them in a grant like this, so we can put those fees into work around the state. So this project goes for 3 years, and it's funded for nearly $15 million. And because the university believes so much in the benefits that we can provide across the state in partnership with the primary care practices, because those are the boots on the ground and the people that really know how to take care of their patients once they have these systems. So that partnership can make just a huge impact, and the university understands that. So almost all this money is essentially being spread across the state to do this work. In primary care, we felt for a long time that if given the proper resources, that we can engage patients in a way that we not only prevent some chronic diseases, but that we intervene early in chronic disease, and we can prevent the advanced awful consequences of those diseases. So the great thing about this opportunity is we can actually go out there and say, grasp the promise. We can tell the practices, this is your time, and we can ask them, are you ready? And we can actually build the systems to achieve this promise in primary care and show America that, that yes, as primary care practitioners, we can achieve these lofty prevention goals, and we can not only help people, but we can make the health system more efficient and make outcomes much, much better.